Shukriya. Thank you. Can you hear us?
Yes, we can hear you.
Okay, perfect.
We can't hear you.
Can you hear us now?
On, on. ठीक है.
No, I mic on नहीं है आपका.
I,
Mus-
you hear, you, do you,
yeah, we can hear Mustafa, but not her.
and you heard the story though, right?
Yeah,
Post-
we did.
post
We already know the
cholecystectomy.
story.
Okay. Okay, so we'll get started then. So just to recap what you were teaching them earlier and just what I was showing, that a lot of the movement's going to come from the left hand and the right hand's going to be supportive. Now, Dr. Hassan mentioned to you that he extends his wheel and does it backwards. I tend to do it like a normal EGD. I usually start with a bit of flex, and then once I'm in the back of the mouth, I flex it more, and once I'm over the back of the tongue, then I'll extend the big wheel because the trachea is in the front, esophagus is in the back. So that's what I'm planning on doing. Lubricant type? Oh, sorry. Okay. So here I'm going to just have a bit of flex on my scope. And I'm looking, and this, and I'm just giving a bit of a big wheel to try and get over the tongue. And as I feel like I may be over, I'll extend it, but I'm not really quite there yet. So I'm going to try and extend and see if I can get across. थोड़ा हिल रही हैं इसको आप. So she's moving a bit, so I'm going to try and get her deeper before I get started. थोड़ा सा lube और दे दो. So we're going to try again. So if it doesn't work out, you don't want to panic. You just want to see, make sure your intubation is okay. Now I'm in the back, you can see endoscopically, and I'm gently going to extend my big wheel and just advance the scope. It's a bit of a blind intubation in these. In this case, I'm going to keep extending, advancing my scope past the heart, and usually I'll come into the stomach and stop. Now, one approach is what Dr. Hassan showed earlier, going from the liver, going clockwise, and then finding your aorta and finding your celiac and going from there. Oftentimes, though, in my sort of routine has become, I will go straight in, go a couple of centimeters in, make sure I empty the stomach. So I'm emptying the stomach, and I'll just quickly move forward and go clockwise. And right away, I'll find myself on the pancreas. So my starting point oftentimes is the pancreas, and then I'll go, this I'll be landing on the body of the pancreas. Ultrasound thoda bada kar. So we're going to just change the depth so we can see closer. And I'll start on the pancreas. My pancreatic duct is pointer. So my pancreatic duct is right there below the probe. From here, if I go clockwise, now I'm going to follow the pancreatic duct towards the tail of the pancreas. So as I go clockwise, there's the duct dipping down, and I'm going to decrease my depth a bit. And as I come towards the tail, I'm going to big wheel towards me and go clockwise and pull the scope back to try and follow that duct. And I'll keep following my pancreas. I'm pulling my scope back. Below the pancreas, you can start seeing the kidney. Once you see the kidney, you know that you're going towards the tail. And soon the pancreas is going to end. Here, as I lose my pancreas, I have my spleen. Now if I have my kidney and my spleen, if I go counter here, I'll see my adrenal. And if I go counter more, I'll see my aorta and my celiac. So same principle, we got all those structures done, but starting with the pancreas. So now I can also go backwards from here. So from backwards meaning what from me is backwards because I start from the body. So now I have the celiac, I can push forward, I can now find the pancreas again, track it down, I see my PD, and this time what I'm going to do is try and track it towards the head. It didn't quite work out, but there. So there's now there's my pancreatic duct. This is a view where now my tip, if I could show you inside the sort of on an x-ray, my tip is now more towards the antrum. You can see the pancreatic duct here dipping, and it's going to actually go behind the SMV. So now it's gone from behind the SMV, and now we're seeing the pancreatic duct going towards the head, and that dilated bile duct that we were talking about, we actually see here. So the bile duct is going towards the papilla this way, and the pancreatic duct is this way. I'm going to put, in case I'm mistaken, I may get fooled by things, I'm just going to put Doppler on here and confirm. And you can see, how do we move this? इसको Doppler को नीचे करना है थोड़ा सा. So just to confirm, there's the bile duct, there's the pancreatic duct. Now if a patient's obese, you may not be able to do this, but in slim patients you can see that. So we're seeing the dilated bile duct, a vast majority of it from the stomach. We haven't even gone into the bulb yet. And you can see the PD, both of them go to the left. Sorry? I thought somebody said something. So now we're just going to freeze it here. And then we're going to just measure it. So set, and you can see the bile duct is about 9 millimeters. The other thing is you want to go wall to wall. If I go diagonally like this, I can make this duct 16 millimeters, but that is not the right measurement. You have to always do like a cross. So be careful when you're measuring, you're not doing diagonal measurements. These are simple things that affect your readings. So that's pretty much my view from the stomach that I needed to do, right? I got all those structures, and from there I just advanced, like Dr. Hassan showed earlier. Big wheel is towards me, suctioning as I go in, looking at that pylorus, and it's a bit of a field thing. As soon as I can see that wall coming towards me, I know I'm already going across. Here I'm in the bulb, and like he said, you want to go up towards the left apex of the bulb. Again, here, this is where sometimes our approaches may be different, but you have to develop your style. Already on ultrasound, I can see my bile duct, and to confirm it, I can put flow on it. As he said, you want your bile duct to be in this range, in the 5 to 7. So I'm going to try and adjust my wheel to make sure that I can bring it back to that 5 to 7 range. So I'm just adjusting my big wheel, my left hand, spinning it to see how do I bring my bile duct up below my probe. And right below the bile duct, you can see the pancreatic duct. So there are the two ducts. Now this is what I was showing you earlier in that talk. If you go clockwise, you're following the two ducts towards the papilla.
Mustafa,
yes.
Your bile duct and pancreatic duct, they were towards the right side earlier.
Yes.
Can you explain what you did to bring that towards the bottom at 6 o'clock position?
Yeah, so again, I'll pull back just to show you. So when I went in, they were more to the right. Anything that is to the right, things that you need to do to bring it towards you is either you pull back the scope, and if I pull back the scope, I'm going to fall in the stomach, or you can also do big wheel towards you. As I do slight big wheel towards me and go clockwise, now I brought it towards me. If I wanted to find the thing, say I wanted to go for the vessel on the left here, right? This vessel, I think it's the IVC. So if I want to go for that, now I have to relax my big wheel and go towards it. So if it's to the left of you, you push in, relax your big wheel. If it's to the right of you, you either pull back or you do big wheel towards you, and you bring it into try and bring it to below your probe. So now the Doppler is off. We're going clockwise to see if we can see it. Now here it's coming to an end. You can sometimes in the bulb trying to figure out if it's stone or not, you can get confused. And this is one of those situations where I don't know if this is stone or sphincter because it seems pretty, currently to me it seems pretty diffusely hyperechoic. So I'm not convinced it's a stone. I don't see definitive shadowing. It just could be a hypertensive sphincter. So right now I'm going to say, okay, I saw the ducts all the way down and I don't see a definitive stone here. I'm going to continue to follow my bile duct, try and see if I can bring it again. Now I'm going to pull towards me a bit, bring it below my probe and go towards the hilum of the liver. Now if you see my left hand, the right hand isn't doing much. In fact, I can do a lot of this with my single left hand. You see that? All I'm doing, using my right hand for is to push in and pull out a bit. A lot of this movement is coming from this left shoulder, like we keep saying. So you just have to keep that in mind. As I drop my left hand, I extend my big wheel and I keep following this bile duct all the way up into the liver. Now we're in the liver and even the intrahepatic portion, you can see is dilated in her. Right, all the way there. You can see this is still bile duct, but look at where my hand has gone, my left hand. If you see, my left hand is now pointing towards my feet. So it's a confined space, but safely you can go all the way from the feet all the way up towards my sort of chest. Here I lost the view, but to show you the point that you can go safely basically with your scope just with movements without too much tension on the scope. If you're torquing in the bulb, you can cause damage, so you don't want to do that. So now that we've done the second portion, the other thing, sort of things that Dr. Hassan already mentioned, if you're lost, if you can find the portal vein, the largest structure typically is your portal vein. If you find your portal vein, you can orient yourself. And usually, like on the CT scans, you'll see the bile duct is between the portal vein and the duodenal and the probe. So if you find your portal vein, you may just be compressing the bile duct. That's another important feature. So look at this. I can compress this bile duct a lot just by pushing my scope and my probe. Oftentimes with trainees, they're like, I don't see the bile duct. All we say is relax your big wheel, you push away from it, and all of a sudden you find your bile duct. This is a very dilated duct, so it's hard to miss. But if it's a smaller normal duct, you may miss it. And all you sometimes do is relax the pressure in the bulb, and you will be able to see your structures. Again, portal vein, pointer.
So, Mustafa, you are close to getting towards the hilum. Can you explain bile duct to make sure that you got all the way to the end of the papilla? How you determine that? Because sometimes what happens is, like the pancreatic duct and bile duct, they may be traveling parallel to each other for 2-3 centimeters into the head of the pancreas.
Yes.
So when they come close to each other, it seems like you are at the papilla, but you are not.
Yeah, and one of the exactly
from it.
Exactly.
So if you can explain that.
Sure. So one of the things you look for is air in the duodenal wall lumen. So once they come closer, you keep coming together. You can see it becomes darker where the sphincter muscle is. So I'm looking to see if the sphincter muscle is right about here, right there. And then you can also look for air in the duodenal lumen to the left of it. That's typically one sign. And then basically the MP you may see dipping down here too, right there. So those are usually the ways I would do it, but if there's anything else you'd like to add, Dr. Hassan, please do.
No, that's pretty much it. What I look for is, like I look at what we call the duodenal fall, the muscularis propria of the duodenal wall. When you get close to the ampulla, you're going to see it's falling down that muscularis propria, and your bile duct orifice is touching that. That means you got to the papilla, and your pancreatic duct, if it's a normal anatomy, will end up right there, and they both would be connected to it.
Okay, so now we're going to go to the second portion. What I typically do is, while I'm in the bulb, a lot of people start doing various maneuvers. Sorry, the voice is not clear.
Yeah, I think the mic needs to be put on your right side instead of left.
Okay.
Because the screen is on the right side and
Yes.
you're turning away from the mic.
Thank you. So I hope this is better. So what I typically do is a lot of people will get lost trying to get to the second portion. They're doing all these torque movements, especially with trainees. Simply if you're in the in the bulk, just like in regular endoscopy, small wheel to the right, big wheel towards you. You may want to push in a tiny bit and then you just, I'm not holding the scope from the shaft. Just my two wheels, big wheel towards me, small wheel to the right. I do not lock and I just reduce my scope. And usually just that gentle maneuver of reducing like that basically gets you into the short position in the second portion. From here, my instruction to trainees is, you've been doing all this like this up until now. Turn your body clockwise. It's just like ERCP. When you go to the right, it stabilizes your scope. Turn your body clockwise, look at the screen in front of you. Then extend a bit to look for your major papilla endoscopically. Always try and look at it, especially in a situation like this. You don't know if it's an ampullary adenoma, you don't know if it's a mass. So you want to try and identify it endoscopically, and also it orients you for your EUS exam. So there's my papilla, we can see it, and to me it looks normal. इसको थोड़ा endoscopic बड़ा कर देंगे. So oftentimes, you know, it will be behind a fold and you may even want to use a biopsy forceps to just look at it, make sure you're not missing a lesion. But to me, this looks pretty normal. But I'm getting a sense of it endoscopically too, that it's a prominent papilla based on my endoscopic evaluation. Now, this is where I think Dr. Hassan and I do things differently, but we both get the same result. I think you have to understand what you want to do is figure out what works for you and then go with that. So now I have my papilla in my view. As he said, if I'm at the level of the papilla, that my probe is going to be distal to the orifices of the ducts. So I'm going to go clockwise, and if in front of me is 12 o'clock, I usually turn my body more to the right about 2 o'clock, put the big wheel towards me, ultrasound, and I will usually go clockwise, so opposite of what he did. And I will look for my mesenteric vessels. So SMV, as I go all the way clockwise, SMA, then SMV, and basically from here I know that I'm all the way over to the other side of the uncinate. Now I'm going to gently go counterclockwise to evaluate the pancreas. That bright portion is this is the uncinate, it's bright. Okay, the uncinate is going to be bright. I'm going to increase my depth a bit. As I'm clockwise, there are my vessels. I pull back a tiny bit, I go counter, and I'm looking for my ducts. If I don't see my duct, I'm going to stop and go clockwise again. I know I saw a bit of it to the right, but there's no rush. I'll bring it to me. If I keep going counter, I'm going to fall into the stomach. So I'm going to go clockwise back to my uncinate, pull back my scope a tiny bit more, and do the same maneuver here. Go back clockwise, pull back a bit more, and study. Part of it is you're studying the uncinate to make sure you're not missing a lesion. And now I have my two ducts. I have my pancreatic duct below and my bile duct above. Here, the question is, we want to know the very distal tip of the ducts, because that's where we suspect there may be something going on. So you want to, if you're too tight on the big wheel, you won't see that. So you have to relax your big wheel, and you're looking for it. You also may want to increase your depth more so you get closer up to it, and you're just relaxing the big wheel and studying it. This area here, if I can just freeze right there. इसको हटाना पड़ेगा. How do you, oh yeah. So I'm going to do that again. So this was my area of interest. So you see this tissue here is all isoechoic. It's not too dark to be a mass. It's not a round structure with shadowing to be a stone. And this is basically this is your papillary sphincter muscle. And if you stay on there, you may even sometimes see it contract. You may see movement in it, and there may be contraction of the muscle here. The other thing you can do is इनका head थोड़ा ऊपर किया जा सकता है, like head up, मुझे थोड़ा सा पानी 60 cc strain में. The other thing you can do for ampullary lesions is
So this is muscularis propria right here, sir?
yes, please. You can also put in water here to get a very nice interface between the sphincter muscle and your probe. You see, now that we have water, we can
That's
make out
muscularis, you see
muscularis right there. You can see that. I think Dr. Hassan's pointing it out. But this black wall here, so that's your MP in the duodenal wall. And there's your sphincter muscle right there. There's your PD coming in. So this is what you're looking for right there. So you can see there's no mass. There's no mass and there's no stone. Because if you had a stone, usually you would expect to see a shadow from here. So just a little bit of water, 60 cc, has cleared up our image. Because remember, ultrasound waves will go right through fluid. And so you go from a somewhat mediocre image to a very high quality image simply by putting water in there. And this here is just the sphincter muscle that we're looking at. So basically what you're looking at is benign papillary stenosis with a dilated duct. And the question is, to have a conversation about with the patient about the risks and benefits of ERCP, which I assume we haven't talked to her about it, but that's something that can be proposed to her. And there you can cleanly follow it. Now sometimes if you're lucky, I'm going to reduce my depth so I can follow the ducts. So now that I have them in view, if I want to follow the bile duct, if you look at my hand, I'm going to go counter. As I see my bile duct, as I pull back.
And if it's a mass, it would not be isolated.
I can go counter, but for pancreatic duct, I have to change my orientation of my scope and figure out how to follow it. So if I want to follow pancreatic duct, I go more clockwise. The other things, a couple of other things you have to remember is uncinate is bright, dorsal is bright. So above this, back to the cursor, above the dorsal is bright, the ventral would have been dark. We're losing position here, and then the uncinate is bright. So remember, the pancreas above the duct, which is bright, is going to be your dorsal duct. So if I want to follow the PD, I go more clockwise. The pancreatic duct currently is here. You can see it. Because I pulled back, you don't see it very well distally, but the pancreatic duct is here. And if I keep it in view, you can pull, there's the PD, you can see it and gently keep pulling it back, slowly trying to follow it. There's the portal vein coming into view to the right of the duct. And we're going to see the pancreatic duct go over the portal vein right there. So similar to that gastric view we had earlier, and this time we're following it from the papilla back towards the body, neck, body area, and the scope usually falls. Right there it fell, and then you can follow it back towards the tail. So you can do a complete pancreatic duct evaluation all the way from the papilla to the tail. And now you can see the duct in the tail with the kidney behind it. And eventually we'll lose the pancreas, but we keep following it till we lose it. There's the spleen. If I have spleen, if I have kidney, if I go counter, there's going to be my adrenal, and that's going to be your celiac right there. So that's pretty much all we needed to do. We've evaluated it. For completeness sake, we can unmag and keep going counter here, and we'll get to the liver. And basically we can evaluate our liver, go clockwise and find liver, and we can evaluate the liver. She has intrahepatic duct dilation as well. Look for any obvious lesions, and then we're done with the abdominal portion of the EUS. To recap the structures, I'll go over just two basic stations or areas in the mediastinum. One is that level 7 that I was talking about. So in the mediastinum you have to unmag a bit. So left atrium, left ventricle, aortic valve. This is perhaps one of the most sort of mesmerizing images, seeing the valves kind of open and close. And if you just spin your scope around here, you get to the subcarinal region. So that, so cursor off. And if I can just show you here, this area here is your subcranial region, about here. So you'll be looking for lymph nodes in that region. There's the trachea, so you can see shadowing of the trachea. So you just spin around here, and that's a tiny little node or a vessel, I can't tell, but in that area. So that's one station to be looking at. And the other one is if you keep following your aorta, so you go clockwise, there's the trachea, so tracheal rings, there's your aorta, aortic reflection, you pull back a bit till you're at the arch, big wheel towards you and clockwise. Patients will get uncomfortable with this. This is 4L. You see the two eyes, pulmonary artery to the left and aorta to the right, and this is 4L. There's a little lymph node. This is station 5. That's the AP window. So basically, these are the two areas mostly where you'll find lymph nodes. But remember, this is where patients do get uncomfortable and you just can pull out. So my conclusion on this would be dilated bile duct, normal pancreatic duct, likely secondary to papillary stenosis. If she's having classical pain with bumping LFTs, I would offer an ERCP with a sphincterotomy.
Thank you.
Thank
Excellent
you.
demonstration.
Thank you. Benign pain. Exactly.
And stenosis is one, and the second sodium is
वो एक ही चीज़ है. They change the term.